It's a great pleasure to be with everyone today. I'll go ahead and introduce my panelist and the operator. We've got Professor Ömer Gökteki from Memorial Hospital in Turkey, who will present an exciting case. And with me, I've got three great panelists. We've got Dr. Şevket Borglu. He's a professor of cardiology in Turkey. We've got Professor Nihat Kalay, who's a professor of cardiology in Turkey as well, and Dr. Asad Akbar Khan, who's an assistant professor of medicine at Sinai and currently working as a consultant interventionalist in Shiva, Pakistan. So it's a great pleasure to have everyone with us today. We do have an exciting live case. It's a calcified lesion and the use of rotational atherectomy. But before we go on and jump to the case, we have very short lectures that we will cover. I will start with the first one, which will be a summary of calcium lesions and calcium modification tools. So I'll go ahead and share my slides. Just give me 1 second so I can play it. All right. Okay, so as I said, before we jump into the live session, we've got few talks. We'll start with the first one. It's only going to be a short lecture about approach to calcified lesions. The whole idea of doing a calcium modification before you stent is that you're trying to avoid what's in this picture here. So when you go ahead and place a stent in an area that was not prepped well and it's severely calcified, you'll run into issues with under expansion and malapposition, and this will be one of the major predictor of worse outcome in the future with ISR and stent thrombosis. So there are multiple algorithms. So I'll try to cover two of them and be precise to the point and what is it exactly that we need to know when you're approaching calcified lesions. The first thing that you do is that if it's a lesion that you can't even cross with a balloon, then your strategy should be right away with an atherectomy, whether it's rotational or orbital atherectomy, depending on where you are and what you have available. The idea is that you should wire it and then use a microcatheter and then change the wires. But if you can't even do that, then direct wiring is another alternative. However, if you can cross it with a balloon, we've got a lot of other strategies that we'll talk about in the next slide. But the tool that you'll be using before to identify which one to use is intravascular imaging, whether it's IVUS or OCT. So if you decide to use OCT, we've got criteria to use. On the top, you can see that we look at the calcium thickness. If it's greater than 0.5 millimeter, it gives you a point. We look at the arc. If it's greater than 50%, that also gives you a point. And if it's greater than 180, then gives you 2 points. And then we also look at the length of the lesion. So anything more than 5 millimeter will give you a point. We'll talk about the scoring in the next slide. Another criteria that's been used with IVUS is that pretty similar. So you look at the calcium thickness, you look at the circumferential of the calcium and the length of the calcium in terms of arc, more than 270 would give you a point. You look at the diameter of the vessel. So if it's a smaller vessel, that gives you 1 point. And if it's a calcified lesion, yes or no. So based on those, so you would do first IVUS or OCT, and then you'll see different patterns of calcium. If you have, as we talked about, uncrossable lesion, or if you have calcified nodule, the use of atherectomy is extremely important here to make sure you have you've prepped your lesion very well that you can have an expanded stent. If you have deep calcium, the atherectomy devices and IVL might not get to it, and sometimes NC or scoring and cutting balloon might be an alternative. If you have superficial calcium, then that's when your scoring methods that we talked about becomes handy. So if you have less than 2 of the following criteria, which we talked about with OCT, same thing with IVUS, then a cutting balloon or NC or scoring balloon might be all you need. But if you have more than 2 parameters of the ones that we talked about, then IVL or atherectomy, intravascular lithotripsy or atherectomy would be a useful tool. The other thing moving on forward, if you want to make sure you have the best results, is that after you do your calcium modification technique, it is advisable to use an NC balloon, make sure that it's well expanded, or use OCT or IVUS and make sure that your calcium has fractured. If not, then you go through the whole scenario again. This is just to illustrate how the use of any of these modalities can give you a calcium fracture. In this case, it was a lithotripsy, and you can see that the fracture actually went pretty deep, and that will reassure that you can actually have a well-expanded stent. So in summary, if you have non-crossable lesion or if you have calcified nodule, the use of atherectomy is better than the others in terms of making sure that you treat it well. IVUS and OCT really give you a clue about the extent of the calcium. And if it's deep calcium, sometimes NC scoring balloons or even intravascular lithotripsy might be helpful. And if it's superficial calcium, then we look at the scoring, thickness, length, and arc. If you have more than two, then the use of atherectomy or intravascular lithotripsy is better than NC balloons. And then after you've already modified your lesion, it's a good idea to make it a habit to do IVUS and OCT to make sure you have a fracture, and use an NC balloon with 1:1 size to make sure you have good expansion. So with that, we'll move on to the next presentation before we get to the live case. Our next presenter is going to be Dr. Shevket Gurglu, who's going to be talking about the rota cut technique in heavy calcified lesions.
So, as a big fan of RotaCut, I'm going to share with you my own experience. And I have my own algorithm here. This is my algorithm in moderate to severe calcified lesions. As Rasha mentioned, it's almost the same. Uncrossable, undilatated lesions or a nodular calcification is an upfront indication for rota. If we have a 2.0 or 2.5 millimeter small vessel, long lesion, if the IVUS probe passes, then I look at the arc of the calcium. If it's below 180 degree, then I'm trying first with non-compliant balloon, cutting balloon, or scoring balloon. If the arc is greater than 180 degree, then this is a rota case again for me. This is the case. This case was done 5 years ago. Even then, I used to do RotaCut, of course, with the old machine and FlexStorm instead of RotaPro and Wolverine balloon. Like in this case, achieving luminal gain in nodular calcification is only possible through debulking with rota. So first we did rota with 1.5 per. This is how it looks on the left screen, on the right screen after rota. And the luminal gain is evident with some debulking of the nodule. So the first FlexStorm ruptured at the lesion site at nominal pressure. So this is the second 3 by 10 millimeter FlexStorm, which got through with the assistance of a guide extension catheter. One can see how nicely the calcification was modified after RotaCut on the right screen. So here's the end result after stenting. I have 2 reasons for cutting balloon after rota. First is the less recoil and plaque compression effect of the cutting balloon. The second reason, which is for me more important, is the scientific evidence for that. We have this single center observational study indicating better minimal cross-sectional stent area if rota followed by cutting balloon. Another study indicating better stent expansion with cutting balloon after rota. My routine nowadays is RotaCut with RotaPro and Wolverine cutting balloon, which is the newest version of the FlexStorm with better crossing profile. Moderate calcification, you can see a moderate calcification in the LAD, first crossing with the supercross microcatheter and leaving the rota wire in place. We are retrieving the microcatheter. Then here comes the rota with 1.5 per. After rota, 2 by 6 millimeter Wolverine cutting balloon was pushed with the help of a guide extension in the distal part of the LAD. Ballooning begins from the distal part, and then the proximal part. Here is the end result in the right screen after stenting. So this is my last case here. So this is another case. It's a heavily calcified LAD with severe over 90% lesion in the proximal part of the LAD. And again with 1.5 per rota, first doing it very slowly, and you see that the pecking motion at the lesion. And then we have to be very patient in doing this maneuver because you can easily be stuck in the lesion. If we cross the distal part of the lesion and did the polishing in the end, and then comes the cutting balloon. This was a Wolverine cutting balloon, 2.5 by 15 millimeter. We began again from the distal part, then in the middle part, then in the proximal part. The lesion was modified by this cutting Wolverine cutting balloon. And after rota followed by cutting balloon, I 60 to 70% get a result like a stent. You see, this is like a stent-like result here. Of course, in all these cases we did IVUS, but this is going to be a presentation from Nihat, so I have skipped the IVUS parts, but IVUS is very essential in the calcification. And you see the Wolverine balloons, the new Wolverine cutting balloon with improved flexibility and a reduced entry profile. So after stenting, so I have to adjust my, this is after stenting, and the lesion was begun from the left main, so we did left main post dilation, and here on the right screen you see the end result. So in summary, Rotacut, not only Rotacut is a viable solution for moderate to heavily calcified coronary lesions intuitively, but also it is appropriate scientifically. Thank you for your attention.
Great, very nice demonstration of the use of both modality. We'll move on to the next talk. It's going to be by Professor Nihat Kalay, who's going to be presenting on the use of IVUS in calcified lesions.
Yeah, thank you. Hello, everybody. I will say two thanks to Boston Scientific for this session. I am Professor Nihat Kalay, Erciyes Üniversitesi Kayseri, interventional cardiologist. My talk is use of the IVUS in a calcified lesion. Coronary calcification is a major challenge
in a second.
Thank you, Rasha, and thank you, Boston Scientific, for inviting me. So I'm going to go move quickly because we don't have much time. So these are my conflicts. Rotablation, obviously, we're going to discuss in detail during the live case as well. But essentially, all the tips and tricks involved rotate or revolve around two major players. One is the wire, and the other one is the actual console and the device itself. So indications, we have done them, and I think we have another talk waiting, which will go through more indications. So complications. Obviously, the most dreaded one and the commonest ones are slow flow or no flow perforation and burr entrapment. So we're going to go through some tips and tricks to deal with them in a bit. But I think probably the biggest complication is not doing the rota when you feel rota is indicated. We call it the rota regret, and probably a lot of us have seen it, and we always say that if you feel like rota, always do rota rather than putting an under deployed stent. So firstly, we'll start with the wire. So there are two wires which are widely available. One is the rota floppy wire, which is more flexible and torqueable. And then the other one is the rota extra support wire, which is stiffer. Loads of people use it upfront for their routine work, but most people use the rota floppy. It is primarily used for distal lesions, heavily calcified long segments or proximal segments, and then instant restenosis segments. So I think as beginners or even people who are doing it routinely, one thing that makes your life easy is wiring the vessel, especially when it's tortuous, with a workhorse wire and then using a microcatheter for wire exchange rather than trying to wire directly. One thing that you might notice once you have taken your rotablade up to the tip of the guiding catheter, and when you look up, you have this big loop of the rota wire there, and you panic, and what you try to do is you push a guide catheter in, which actually makes it worse. So what you do in these situations, when you see a loop like that in aorta, you pull the guide catheter back a bit and then rotate the wire in whichever way it feels like straightening up, and that usually looks after it. The other thing that you need to be aware of is the guide wire tip. So there is a wire tip torquer that we always keep on the wire, and one of the purposes of this clip is to avoid the tip from spinning. So if you don't have it on properly, you forget to put it on, what you see is something like this, the curled spring tip in the distal vessel bed, which can not only cause dissections, but in rare cases form a knot, which can be a nightmare. Last thing about the wire is that you don't ever advance the rotating burr to the point of contact with the spring wire tip, because that's the point where it can break and cause complication, literally perforations. Even in the DFU it's mentioned, and that's something you need to avoid. Then the other thing you should always be aware of is the rota flush. There is a science behind it. There are studies, especially the Karaf study, which showed that if you use a rota flush, you can avoid a lot of complications. A typical rota flush consists of heparinized saline with verapamil and nitroglycerin. But all of us who have worked in US or who are working in US know that we use a rota glide solution in US, which is not really available in the rest of the world that easily. So one solution to that is using propofol 1 to 2 cc in the heparinized saline, which contains the same or similar amount of albumin and helps make things slippery. In terms of protocol, especially in long lesions where you have a much larger vessel proximally and a much smaller vessel distally, ideally you should use a two-step burr approach. One of the things it helps you do achieve is that it helps you reduce the plaque burden in the distal bed before you actually bring the big burr, and helps you reduce the risk of slow flow. In terms of technique, I'm sure Professor Gökteki will go through that, but one of the things you need to remember is that all the burrs up to the size of 2.0, the highest speed you should go up is 180 RPM, 180 RPM, and the optimal speed is usually around 140 to 150. You always slowly advance the burr. You can never do pecking motion, which Dr. Shefker mentioned as well. Try to maintain less than 5,000 RPM deceleration from the baseline for more than 5 seconds. Ablation time should not exceed more than 20 seconds in one go. And always try to intermittently pull back to improve coronary perfusion, and also maybe a contrast injection every once in a while. All people who are starting off on rota are told this mnemonic draw, and we're going to go through step by step what it involves. So for drip, So you may need to make sure that the saline is dripping from the bottom of the advancer as well as the catheter, not just one of them. And never even test your rotabur without checking for the drip. R is for rotate. You make sure the rotations are optimum. A is for advancer. You make sure there's free movement of the advancer knob, and also make sure that the Y connector is not too tight, because if everything else is right and Y connector is too tight, it might actually not let you move the rotabur forward. And then the W is for wire. Wire should be visible behind the console, and there should always be a torquer on it when you're working on it. Well, in terms of wire position, bird positioning, preferably always keep your knob 1 to 2 centimeters ahead of the bottom, because that will give you some room to pull back into the healthy segment after you have done rotablation, rather than ending up in the disease segment. Preferably a bit more when you're doing oste lesions. When the burr is still proximal to the lesion, relieve any forward tension on the drive shaft by unlocking the advancer knob and pulling it back. So one of the things that we have always seen in all these high volume centers is that the first time you put the foot on the pedal, and if there is still resistance or some tension in the system, your bird tends to jump forward. So one of the things to overcoming the dissection problem with that is that you always jump on Dynaglide first. Always press on Dynaglide before you start rotablating, and then once you've taken the tension out, then you start burring. In terms of getting the burr for distal lesion, so if you're you know that there's a certain length of the shaft that you can only burr, so you cannot always start burring from inside the catheter into the vessel. Sometimes you have to go real deep. So a lot of us use Dynaglide to take the actual the rotabur to the distal segment. But what Dynaglide does not provide us is the drop in acceleration if it's entering a disease segment, and you might end up with an entrapped burr before you have even started burring. So what we recommend is maybe taking the burr at a slightly lower pace to avoid rotablating the healthy segment down to the disease part, and that will help you avoid burr entrapment before actually starting. So obviously, always look for visual, auditory, and tactile stimuli while you're doing it. Make sure you're not pushing the rotablator in, like Professor Shefkat said, always use pecking technique, and try to keep your runs to less than 15 to 20 seconds in one go. Avoid the deceleration to more than 5,000 RPM and for more than 5 seconds. If that's happening, you need to maybe burr slower. Again, avoid dottering. Never stop your burr distal to the lesion. Avoid adjusting the RPMs in the middle of ablation. Sometimes if you're ablating at the same point for too long, that particular part of the wire can get heated up, and especially in ISR segments. So we would always recommend that change the wire position a bit to change the angle of ablation, and also avoiding potential breakage in the wire. And always finish with, you should always finish with one polishing run. So tortuosity, as Professor Shefkat showed, that and rotablation doesn't always go well, and you have to be really on your toes looking for and making sure you don't end up with a complication. The reason being, in a tortuous vessel, depending on at what angle your wire hits a particular tortuosity, your wire might be more biased towards a particular vessel wall. We call it divergence from the central axis of the vessel. So there are two things that you should do if you see a tortuous vessel. Number one, go with a smaller burr first, because that will avoid and reduce the risk of complications. And secondly, rather than doing the typical burring where you keep your wire as far deep inside the vessel as possible, you bring the soft part of the wire back to just below the disease segment, and that will make your wire more coaxial and make your ablation a bit more safer. Always balloon. So we typically keep a rotor wire in and wire side by side with a workhouse wire, because this rotor wire will not only help keep the vessel straightened, but also acts as a scoring wire and a buddy wire when you're doing an NC balloon. And you might save the money that Professor Shefkat wants you to use all those cutting balloons in. And it also localizes the areas of resistance and maybe help reduce chances of slow flow. When you're doing osteal lesions, the primary thing I think you need to be aware of to avoid complications, especially dissection of the osteal part of RCA, can end up with an aortic dissection. So always check that your guide catheter is coaxial in two projections, before you start ablating an osteal lesion. And always consider an extra support wire to keep your coaxiality maintained. Temporary pacemakers, loads of us use it for when we are ablating dominant RCAs or dominant SERTs. Few tricks to avoid it. It can be shorter runs using a smaller burr and then using IV minofilament boluses. How do you deal with the complications? So slow flow. We all know long calcified lesions, total occlusions can cause slow flow. But one thing that we always, a lot of us miss out is that if the patient has poor LV function and a high EDP, that's a very strong predictor of slow flow post-rotablation. The other probably reason and the actual reason for slow flow is mostly platelet activation. Obviously, a lower epicardial vessel pressure makes it worse. So we know from in vitro studies that if our burst speed is anywhere around 180K, it ends up aggregating or activating the platelets a lot more versus if you keep the rotation of the burr around 140 to 150K. Hence the recommendation of using a slightly lower speed. So how do you avoid it? Speed around 150K, short runs, avoid RPM drop, and avoid hypertension and bradycardia. If it still happens, you can have intracoronary vasodilators, intra-aortic balloon pump and impella if nothing else works. Perforation. I think perforation is something that you need to avoid rather than deal with. And so for that, you need to be sure if you have any of these characteristics in the vessel wall, you are aware and you need to be more careful. If there is a more than a 90-degree bend, eccentric calcium, which you can easily see on IVUS, which we'll hear from Nihat, large burr-to-artery ratio and total occlusions, these are the settings when perforation happen. So again, if any of these is present, go with smaller initial burst size, try using a rotor access support wire, and maybe in some cases you can pre-dilate with a small balloon to feel how the vessel behaves and avoid RioPro upfront. So lastly, stuck rotablator. That's a nightmare of rotational atherectomy. And luckily, it doesn't happen very commonly. Usually happens with the smaller burrs, particularly the 1 to 5 burr. Again, loads of algorithms. People have shared their data in case reports and case series as to how they deal with it. Probably the simplest method and probably what we all have done and used is pulling back the rotablation system manually. Luckily, most of the time it works very well. But one thing that you need to be aware of is when you're pulling on the rotablator system, your guide can deep seat and you can end up with a dissection above a stuck burr. So you end up with two complications. Very easily you can avoid it. Disengage the guide from the vessel ostium before you are planning to pull back on the rotablator, and also put another guide wire deep into the aorta that will help prevent your guide catheter tip engaging deeply into the vessel. If that doesn't work, you can wire side by side with another guide wire and then put a balloon on it and which will help deflect the rotablator. Now that was easily doable in the older days when we used bigger guides. In this day and age, when we're using the 6 French guides, what we need to be aware of is that the profile of the rotablation drive shaft is around 4.3 French. And the balloon catheters are usually 2.5 to 3 French. So inside a 6 French or even a 7 French guide, there's not enough space always for the balloon to go in. So very easily you can avoid it. Take a second access, stay calm, wire side by side and take a balloon there, and that might help you deflect the calcium from the rotablator. If that doesn't work, next thing is probably using snares or mother and child catheters. Before you do that, so I've seen people panicking, and what they do is they cut the drive shaft here, and that leaves them with no room to actually pull back on the guide on the rotablator system. So try to always cut near the black part, because that will give you all this room to hold on to the actual rotablator and helps you pull it back when you are deep wedging the mother and child. So easiest thing, if you don't have a microcatheter, put a 5 French guide inside the 6 French guide and help deep seat it and wedge it between the rota as well and the wire, between the rota and the vessel wall, and then gently pull on the rotablator system, and that usually relieves it. Other thing that you can use is a guideliner or guidezilla. And then the next thing, if none of this works, is a percutaneous snare that some people have used. Lastly, if none of this works, go early for surgery, and they can easily see what we have done, and hopefully they'll be able to help the patient in time before anything wrong happens. Thank you.
Excellent. Very great summary of complications and how to deal with them, and as importantly said, how to avoid them too.
Yeah.
We'll move on to Professor Nihat Kalay. Do you want to go ahead and present your IVUS talk?
Okay. Hello again. Sorry.
Yeah, we can see your slides. If
Yeah.
you
Okay.
can't,
Okay. Thank you. Yeah.
if you can't play it, just go one by one. I think that should be fine for now.
My talk is on use of the IVUS in calcified lesion. Corneal calcification is the major challenge during to PCI for all interventional cardiologists. It is related to suboptimal PCI. For ultimate study, we know that suboptimal PCI is closely related to stent failure 1 year and next years. Mainly, we can define three conditions related to suboptimal PCI. Undersized stent, malposition, or H dissection. Unfortunately, when we perform IVUS in our real practice, we can see this condition in many patients.
Nihat, we got stuck in the first slide, so it's not moving. I think you are now on the third or fourth slides, but still we only see the first slide.
First
You
slide.
can, yeah, we are.
Slides now. You can go ahead now.
Okay, can you see?
Yeah, we can see it. Go ahead.
Yes, please go ahead.
Yeah, sorry for this problem. Subintimal PCI, stent under expansion, stent malposition, or HT section, we can see, unfortunately, many patients. Other problem with calcification impaired stent delivery. We can see the degree of the calcium score and under expansion rate. If you have high calcium score, your stent is probably undersized without IOS. How can we evaluate the coronary calcification? Is conventional angiography sufficient to detect or evaluate the coronary calcification? Answer is no, absolutely. As you can see in this image, IOS is more sensitive technique to detect coronary calcification compared to conventional angiography. In angiography, can not detect calcification in about half of patients. In IOS, we can detail evaluate the calcification. To determine the degree of the calcification, we need to evaluate calcium thickness, angle, length, superficial or deep calcification, calcified nodule, which it is related to acute coronary syndrome, or it is also give some information about the next procedure, rotablator or NC balloon technique. How can we describe the severe calcification? In angiographic definition is that radiopacity seen without the cardiac motion, usually affecting both sides of the arterial lumen. There is no clear definition, IOS definition for severe calcification. In IOS, we need to evaluate the different parameters for grading the calcium severity. That is angle, calcification thickness, or length is so important parameter. Calcified nodule is important point I mentioned before slide. You can see the calcified nodule. Calcified nodule are defined as convex shape of the calcium deposit on the luminal side of the arc vessel. This is fibrotic plaque, and it is not nodular calcification. Also, you can see acoustic shadowing. Angle is important, calcification angle. You can see circumflexial calcification. The deep, as discussed before slide, calcium should be described according to its location. If calcium location is close to intimal and is located at superficial 50% of the plaque, we define it as the superficial calcium. You can see superficial calcium. Calcification close to lumen. Also, you can see calcification gray color. And it is located the deepest 50% of the plaque, and it's close to adventitia. This image. This means deep calcification. You can see other animation. Dr. Raja mentioned actually this algorithm. We are different algorithm to manage the calcific lesion. In all algorithm, we use of the IOS is essential. If calcification arc, calcification length, also thickness is important parameter. If you have any of above parameter, or you have deep calcification, you need the adventist technique to perform optimal PCI. If you don't have the none of them, you can use a non-compliant balloon or scoring balloon, use your patient. Other algorithm, you again need the intravascular imaging to evaluate the calcium arc, length, and thickness. If you have 1 or 2 point and non-compliant balloon may be sufficient, but otherwise you need the rotablator lithotripsy techniques. Other different algorithm. If you have vessel narrow than 3.5 and you have calcified nodule, atherectomy should be considered for optimal PCI. Calcified nodule, you can see 2 o'clock position, all circumflexial calcium. One case, I will show you one case example. Maybe internet problem, actually the video format.
Nihat hocam araya giriyorum kusura bakmayın.
We can go to Professor Ömer,
Yeah.
they're ready, and they can present the case, and then towards the end, we can come back to your slides at the end. Can we check and see if they're ready with the live case?
Rasha, can you hear me?
Yes, great.
All right, and you can see me, right?
Yes, we can
Okay.
see you. Great
Right,
to see you.
thank you. Thank you very much. First of all, I'd like to thank Boston Scientific for giving us this opportunity. Today, we like to do a rotablation case with you, and I'd like to introduce my team. I have Ahmet Shakir on my left and Hashim Tuner on my right, and I have Gizem as a nurse and Samet as a technician. So, before we start, I'd like to ask Mohammed Hashim, who's from Pakistan, a fresh fellow of me, he will present the case for you. Go ahead,
Okay.
Mohammed.
Thank you, sir. Today we have this calcified lesion. We have 62-year-old of gentleman who presented to the emergency department, not in our hospital, but somewhere else in the other city of Turkey. He has 20 pack years of smoking. While on ECG, he was diagnosed as an inferior wall MI and shifted to the cath lab with informed written consent. So on angiography, there was a diffuse severe lesion on LAD involving both the diagonals. You can see a highly calcium coronary on LAD. While there was a severe diffuse lesion on circumflex starting from ostium, while as it was evident from ECG, there was total occlusion of RCA from mid-segment. So he was dealt accordingly. Primary PCI of RCA was done, and TIMI-3 flow was achieved. In index hospitalization, he was a stage PCI to circumflex has been done. And meanwhile, as there was the circumflex gets total, but he again rewired and some flow was achieved. Then on the same setting, FFR to LAD was done. As it was looking in some views, it was moderate lesion. So FFR was done, which showed significant. So it was 7.5. So then again, he contacted Dr. Ömer Kortigan for further treatment. So here we have this patient on our table in Memorial Hospital Cath Lab. So this is the plan for today's session, and I hand it over to Professor Dr. Ömer Kortigan. Yes, sir.
Yeah,
Thank you.
right. So let's show you today's angio we have done. Can you come the first image for us, please?
Yes.
So you saw that the RCA and circ lesion already treated, and this is circ, looks very nice. Although the final image of the small circ is not good. After 2 weeks, we have nice circ filling. Do you see that?
Yeah, it's
Yeah,
definitely
it's
bigger
better.
than what you left with.
Yeah, it's better now. Okay, so I think the expansion of this stand looks quite okay for us, at least by angio. This is spider view.
Previous
Can you
one?
come back
Previous one?
spider view, please? In
Yes,
here,
yeah.
what do you think for the ostium of the LAD? It looks definitely calcified, but also there is moderate stenosis at the ostium of the LAD. Do you agree with me in that position?
Yeah, I agree. We'll go around too before you jump into the case. Just going through the panelists here. Shafkat, would you just try and see balloons first and see what happens?
Let me show you. Yeah, sorry. Let me show the fresh angio, and then you.
Yeah,
I like you to discuss this case, and also maybe I can show you the ILS first. Oh, this is long lesion. You know, according to angio, I think there could be a breach at the end of the a lesion. We have first and second diagonal. First diagonal is, you know, sizable, but the second one is good diagonal. We have to take care of that one for sure. Next, please. And it looks very heavily calcified. The lesion is eccentric, I would say. Next, please.
This is last one.
Okay. Then we did IVUS before connect you to show you IVUS. And let's see the IVUS first. And then you can discuss. Make the IVUS image the
Bigger one.
bigger, please.
Did you have trouble advancing the
No,
cath?
no, it was straight. No, straightforward.
Yes, play.
Okay, yes, play, please. This is
the Opticross? Is this the Opticross IVUS?
yeah, this is the Boston HD IVUS, Şevket.
Rota, bro.
And this is the distal healthy part. In here, the vessel around 3.1, and now we are coming to disease part. Not that much calcification here to my view. There is a breach here. Do you see that the breach? There is a breach from 8 to 11. There is a breach here. I think looks like it's not maybe it's not maybe the best example of breach, but I think there's a breach there. And we are coming to proximal.
See, it looks like they're tandem lesions there. There's one earlier that we just saw, and this is the
Right.
second two.
Right, yes. And we are the
Can I say
diagonal is coming, and this is
Yeah, moderate calcium.
Cranial.
Severe.
Cranial. Önceki.
Yeah,
and
severe.
here we have heavy calcification.
Yeah.
Here is almost 360,
Right.
Mm.
and so we have very calcified lesion. Then we can't see much beyond the
Yeah.
calcification.
Right. So great shadow example of
Yeah,
typical
true.
calcification on IVUS. And I'm assuming you went all the way to the left main, which we're probably about to see in a
Yes.
second. Just to see how significant that the osteo lesion is.
Okay, now the circ will come, and please note the ostium of the LAD. If we cover it or not, that's I think the important decision we have to make. If we stand LAD from the left main or not. This is the circ, and it's just they practice stand that just the ostium, which is nicely. So this is left main. Left main is around 5.5. Yes, this is the IOS before ablation.
Excellent demonstration.
Yeah.
We'll go around just quickly to see how much would be feel comfortable stenting right at the ostium, or would you extend it to the left main? Shafkat?
Before you ask my opinion, I wanted to see the IVUS. So IVUS is very mandatory in deciding how to proceed in calcified lesions. So Now we have the IVUS, so we know the vessel diameter, so we have a 360-degree arch calcification there. We definitely should go with the rota there. At the proximal part, I would like to measure the minimal lumen area at the osteo part of the LAD, and then I would decide whether I go through into the left main or not. But this is definitely going to be a rota case for me, according to IVUS.
Professor Nihat, how would you approach this?
I suggest the rotablator because there is a circumflex calcification and calcific nodule. I see area calcific nodule. Also long segment calcification. There is a good rota indication. Also circumflex ostium was good in IVUS. Two options is reasonable. Maybe Ballon-Gale technique for use, circumflex ostial, for prevent the plaque shift. But crossover the left main is more reasonable technique.
Yes.
Dr. Assad, you do a combination of atherectomy and
rota no. So I think rotablator definitely upfront with all that calcium. What we see luckily is that most of the calcium is in the prox and mid segment, so we can size our rotablator according to that part rather than the distal LAD. Again, measuring the ostial LAD MLA, if it's less than 4, definitely then we should cross over into the left main. One thing I just want to mention, that diag, which is the big one, the ostium of the diag looks slightly retroflex. So hopefully the wiring of that one won't be an issue. We really need a two-stent strategy in the diagonal LAD. It's a long lesion. So probably if we can avoid nailing if we can avoid coming into the left main and making it a double bifurcation case, that would be great. So definitely agree with Sharkir. Look at the ostium of the LAD and see what the MLA is. If the MLA is more than 4, I won't come into the left main.
all right. And I can see with this eccentric calcification, atherectomy is definitely a great approach here, as opposed to other modality, NC balloons and IVL.
Okay.
You can go ahead and let us know where you're at now.
Okay, yes. So we just here, we did IVUS and nothing more. We inserted our rota wire with help of Mamba Flex, which is microcatheter we use in CTO. And I use here extra support rota wire. The reason is we have eccentric plaque here, so I thought that is much helpful than flip rota wire. What do you think in that point?
Definitely, yeah.
Okay.
Idea.
Yeah, okay.
Do
And
you typically use it routinely in most of your cases, or you selectively in the ones with very eccentric?
right. So today we are using Rota Pro. We have Rota Pro, and it's almost ready. I'll show you how we prepare it. We of course connect it with the liquid, and we have to open and make sure if the liquid is coming. This is important to see, and liquid is coming.
Yeah. Professor Ömer, before you move on, just quickly, Dr. Assad mentioned the good thing that we usually use the Rotaglide. It's already a done solution for you in the US, but in the Middle East, you do your own. Do you do your own solution?
What as you mean the as operator?
Rotaglide.
No, I mean
No. We don't use the no. We don't specific fluid for that. No.
But since I have heard it from Esad, I am doing it now in all my procedures. And I don't know how helpful that is, but since then I haven't encountered any stuck of the wire in the rota. So I think it might be some kind of helpful. And propofol just 2 to 3 cc in the bag. And we should also be sure that the fluid is dripping very fast, because if you don't have the fluid dripping very fast, the wire gets stuck on the rotablator. So we should check that, and I have learned that from Esad. Thank you for that, Esad. Propofol would be a good solution.
All right, I didn't use it anyway. We have in our bag we have 5,000 heparin 5 milligram verapamil and 5,000. How much? 5,000. 5,000 nitroglycerin. All right. So now I am inserting rotawire into wire port with carefully.
And what size burr you're using?
Ah, yes, that's
That's
important
very
question. Sorry. I'm using here, what do you suggest, first of all?
What is the vessel size on the IVUS?
The bend
What's
is-
the distal
It's,
vessel size?
yeah, the distal is trio. When you go to the proximal 3.540,
175.
175. Okay,
175 because probably your calcium is mainly proximally.
yeah,
So maybe a 175 well.
right. I choose the same 175. Yeah, because if we can start with the smaller one, but the cost will be doubled. So we choose 175
Directly.
for the one. So when we insert the wire, the rotablator catheter should be straight, and we should aware that not to bend of rotawire, by advancing the bird. This is very important. So now, did you have the wire there?
No. Not yet.
And Ömer, can you give us some insight about your setup? Is it a radial procedure? Are you doing it radial,
Yes.
7 French, 6 French, 8 French?
Press.
How is your setup?
Bas oraya.
Seven French.
Yeah, sorry. We are working over 7 French EBU by radial approach. Okay, a little bit more.
Yes.
Okay, here, stay
Yes.
here. We will do some control. And now I insert my burr. So, where is wire clip? This is wire clip is very important tool. Before testing, we should, wire clip should be set at the end of the wire. Otherwise, when we do test, the wire will be king.
If you can have the camera right at the bottom, yeah, great.
Yeah.
Causing a knot with
You
the
can-
swelling of the wire is a nasty thing.
Yeah,
So
you
everyone want to avoid
Right,
that.
you can leave this wire clip over the table, or you can set it at the docking port, which we will do.
Yes.
All right.
Keep it
So
straight.
now, yeah, we have to straight. So do you see that? And
Yeah,
And, yeah.
you're going to do a test
then
run.
we push the advanced knob to start rotating burr, and we will see it.
Yes.
And we will test it. I like to have 185,000. It could be 180 to 190 RPM. Let's do it now. Can you show the camera?
The device.
We would like to see
Keep the
the
device to this
proximal part of the board. Can we see the proximal part of the board, please?
Yeah,
Yes, exactly.
yeah, okay. Make it 185, Elif. All right.
We would like to see how the fluid is dripping.
We have to make sure, burr is smoothly rotating when back and forth. Okay, stop please. Yes. Okay.
Yes.
And we always want to make sure that the burr is not touching anything.
Yes.
So
Anything.
Yeah.
Right.
Yeah.
So we have to be aware not to wind anything in rotabur. Yeah, very important during the test. Right. So we can insert it now. When we do insert, so before we insert, we have to insert advanced knob, like to the ahead of the rail and by 2 fingers, to get the room for pulling it back. So it's like that. 2 fingers width. We are ready to go.
Yes, keep it straight.
When we go inside, you are ready?
Yes,
Okay.
I am ready.
We like to have dyna mode. Okay, we activate the dyna glide. You see the screen we have in the Dynaglide? Show them.
Any
And
comment about the Dynaglide?
Yes.
I don't use a Dynaglide for going in.
Yeah,
What
we-
about you, Esad?
all right, yeah,
I
we,
always do. I always press the first pedal on Dynaglide
Oh.
before even starting burning. So I always go up and come out both on
Yeah.
Dynaglide. But
I-
I don't go on activated Dynaglide going in.
All right.
Yeah.
That's what you mean.
all right. It's a bit depends. Also, we keep the
Just
brake.
makes it easier probably. Yeah.
True. Yeah. Also, we keep the brake unlocked while advancing the burr. That's important
Yes,
issue.
it is.
All right. So we are in the Dynaglide and insert.
Yeah,
me.
insert.
Yeah. Go ahead. Now, while it's coming back at the end, you see.
Proximal.
Yeah. Go ahead.
Proximal.
Göstersene. Go. Güzel.
Probably watch the tip of the wire.
Left main'e biraz daha gidelim. Tamam. Biraz daha git. Biraz daha gidebilirsin. Gidebilirsin. Git. Left main'e gir. Tamam. Okay. Stay. Yeah. Okay.
Stop.
So now we are in the left, almost left main. I didn't go. I could go a little bit further, but let's start from here. So we are ready. Before start, I'll come back at the end of the rail, like this. Do you see my hand? Yeah. Okay. Now we are ready. So we have to advance the burr up to the platform enough a part of the lesion. We have to make sure we didn't, start the lesion. We didn't, occlude the artery. This is important.
Yes.
Now I glide off.
No. This is
Yeah. Right. Are we ready?
Yes.
All right. Okay, let's start. Dynaglide off. Do you see the screen and everything, guys?
Yeah. Yeah,
Okay.
we can see your hand on the rota and we can see the anterior as well.
So we have to push gently. Now I don't have any resistance so far. Each round should be around. I have some resistance here. If I have light resistance, I can push forward. Okay, stop.
No, you're true.
About wire. Keep wire.
So I come a little bit back. We have
Can
to
I
do
push
yeah.
my wire?
Yeah.
Slowly?
A little push gently. Yeah.
No, I cannot.
Okay.
Because it is.
Yeah.
Probably lock. Yeah.
Hold the wire. I like to
That's one of the reasons why I always use a microcatheter to deeply insert the rota wire. So the rota wire should be as deep as possible.
Yeah, I will insert it a little bit more with Dyna help. Okay.
That's a good trick.
Yeah. So anyway, let's push a little bit forward, and I'll do a little bit more. Yeah. I will start from here
Again, yeah.
again. Each time, each run, it has to be 15 seconds. So our pressure is okay. We can give some fluid. Yeah. Okay.
This is nice.
Definitely a change from the first one.
Okay. Another run and okay. Okay. That's important thing that we have to park our burr at the end of the
Kind of,
rail.
kind of.
Okay, not the middle or the other eyes. You have to come back at the end of the rail. I think we did our rotablation. Let's do another position.
IVUS.
And then we finished it. Yeah.
Are you going to do another IVUS?
I will do IVUS again. Yeah.
Okay.
But after dilatation with the balloon.
So it would be very interesting to see what the rota did to the eccentric calcification there.
Okay.
It would be very educational.
Right, thank you. So let's go with again with the dial mode. We will remove it by pushing the wire. I'd like to show you
Scope it.
how we do it. Okay.
The Y connector should also be opened. That's another thing.
Yeah, press it, please.
Important thing.
Copy. Yes.
The dyno should be pressed till the ball comes out.
Yeah, it's
If you
dyno
do it-
glide
if-
mode, yeah.
If you do it early, then the ball gets stuck again in the wire. So you have to pull
Did
everything
you have
out.
it?
Yes.
Okay,
Yes. Exactly. Stop.
okay.
Very nice.
So,
Yes.
okay. It's okay?
Yes. Okay. This is.
You can remove it?
Everything
No.
I am mentioning has happened to
Yes.
me. So that's experience. I can also
We need
give you some
yes.
insights about my stacks. I had a lot of stacks.
Microcatheter.
Ve trap balon.
So we have now, let's do one injection. If we have anything wrong, everything looks okay, but let's check it again.
Yes.
All right.
Yes.
All right. Okay. We
Trap.
did a kind of,
Trap onje trap.
yeah. Did you? Now I'm sending microcatheter. No need. This is
No.
this is
Yes.
long.
Ömer, what do you think about cutting the rotor wire and
Gerek yok,
then
gerek yok.
working about over the rotor wire?
No, I don't like it. I have no reason to do it. This is easily kinked, can be kinked. So I think we have to remove this as soon as possible.
Esat, what do you think? I have seen you working. So
Yeah, we always would wire with a workhorse wire side by side and use it rather than taking this out. This wire helps you in loads of other ways by just staying there.
Yeah, I know. The wire is very important for the operator. We don't use this rotor for the stanting ballooning, right? So we don't know. We don't use that much, but
Yes,
other
yes.
wire, we know everything about them. How
Yeah.
much they tire.
İyi tuttu.
How can we use them? So we don't know. If we use it, we will use it several times in a month, the best. So why I use this?
I agree. I just wanted to know whether anyone do it.
Rica ediyorum. Tamam.
Would anyone do it?
Okay,
Assad, you use two wires at the same time.
2015.
We would
NC
keep the rotor
balloon.
wire in and then a wire with a workhorse wire. So
Boston
the
with.
rotor wire which stays there acts as helps you make your NC balloon as a scoring balloon. It also
aren't
keeps
you
your
worried?
wire substrate.
You do it while you ablate, while
15.
you're doing
2
that.
Distal.
3-0, 3-0.
After,
Distal.
after.
Okay, okay.
Distal,
I was-
distal.
After.
All
But
right.
it's a newer
Yes,
technique.
okay. Yok abi.
I can try it. I like
I
complications.
wouldn't have let's do the chair.
Solving them is fun.
Right. So over the inside the mamba, we insert workhorse wire, which is choice, and we will do dilatation. Before we do trio dilatation.
Scoby.
Yeah, trio. Before we do trio dilatation. But before dilatation, I like to insert a wire to big diagonal, because after dilatation I might have a dissection and it will be not easy to go this big diagonal. What do you think? I think it's time to rewire it if you wire it.
Wait, I would protect it, yeah.
Yeah.
It will be very exciting to see you how to wire that diagonal.
Asaf ver.
Are
Okay.
you using an NC balloon now?
Söyle.
No, this is we are removing mamba catheter, and I like to have another choice, please, for side branch, and we will keep it open for the first diagonal too. We like to.
Son görüntü göster.
Yeah, we like to tell. Okay, how much
It's
the
not that bad.
how much
Esat.
the ACT?
You will do
We
it very
did two.
quickly. It's not that bad in this
2000.
position.
How much is it, and then how much?
It
we can-
was 300.
All right. So our bunu kullandık mı canım?
Ha?
So we give
So
two
in terms
two.
of the side wire,
Bu ne?
the branch, the
Tamam.
wires with
Normal
side
tabii.
wire,
Tamam.
branches. Like, do you always take the workhorse wires, or do you sometimes use those coated wires? Because obviously people are divided on it. Some people think that you might leave the
Okay.
coating behind the stem. If you leave it jailed, the other people might
Cool.
find
Yes.
it doesn't break that easily, so they prefer wiring the side branch with a floppy wire, a more hydrophilic wire. Do you have any preference, or do you always use your workhorse wire like a BMW or flop?
If you ask me, Asad, I don't use hydrophilic wire unless I need it. You know, if I need it,
Okay.
yes, I know. I use, but I don't need. I don't use it if I don't have to use it, because hydrophilic wire is,
Başka tork ihtiyaç var.
you know, very
Places, yeah.
yeah, very slippery. We have easily remove back, and we have risk of easily going intraplaque, and we have
Cranial.
risk of dissection. I mean rupture even with the knuckle. So if I need it, yes, I'm using it. So shake it.
That's
This was,
it.
but this was so easy.
Yeah.
Yeah. So I don't
No
know why
fun.
you are wondering.
No fun at all.
You know, this was the easy
Yeah,
already.
that will look tricky, but it may
So
not be.
let's do another one.
Another wire.
Or yeah, let's do another
funny
one.
when I see you
Tell-
struggling, not
ask
this
her.
one.
Right.
Who needs
Let's write the first diagonal, right?
Tell.
As well. Now, you think?
Yeah.
Tell.
Tel başka tel yok mu? Tamam nif alalım.
Elif, give him a samurai. Don't let them work on choice.
No, it's okay. Choice is good. I'm not that rich. Shake it.
But Elif is rich.
So what do you guys do in terms of if it's
Göstersene.
an RCT, do you
I'll pick
still
it.
use pacemaker or do you do aminophylline?
Can I get the question again?
So if this was an RCA, would you go with pacemaker or aminophylline nowadays?
The question goes to who?
If you're doing a rotational atherectomy in an RCA,
Goes to you.
When you don't know the answer, you asking. Who asking who? He's asking you.
Yeah, she's asking everyone.
He's asking you.
while you're getting
Okay,
this.
she's asking me. So I do both. If I see a long lesion where I see there is going to be a very high likelihood of
Epicardial?
slow flow and stuff, I will probably preferably put in a temporary pacemaker. If it's a short lesion, I can get away with short runs. I will try to avoid pacemaker. So I'm not 50-50. I haven't totally moved away from a temporary pacemaker yet.
Yes, please.
Yeah, by me it's up to my mood. If I want to go on very aggressively, and if I want to work in a more aggressive manner, then I definitely go with the pacemaker. If this is a big RCA, and if I'm going there with 2-0 burr and want a debulking rather than modification, like a more debulking, then I would go with the pacemaker. But usually when I go with the 1.5 burr, then if you work in patience and if you work very slowly, you don't need any kind of pacemaker. Of course, you should always be looking at the pressure and at the rhythm. That's the key.
So essentially both, like you haven't really moved away from pacemaker completely.
Yeah.
So walk us through what you have there. What balloon do you have in there?
3.0 15 quantum maverick, right?
Wow. You are rich.
Sorry?
You are rich.
I have to
Quantum Maverick.
I have to use NC. And let's touch here too, yeah? We have to be careful.
This is an excellent balloon.
Go,
This is an excellent non-compliant balloon.
I think we have to cover all the way right up to here. Down.
Why don't you have the thinking of using some kind of scoring or cutting balloon? I'm just curious about.
I use already Rota, which is okay for me.
Enough.
If I couldn't
For you.
open it, then I'll try
Yes.
maybe
balloon.
cutting balloon. Yes, we may need it to be honest. Yeah, I agree with you. But now let's try with the NC.
So
okay
open nicely. This is one of the lesions.
It's opening nicely, but before inserting the
go.
stand, I like to go at the proximal part. I like to go with the 3.5 down, up and down.
But also
16,
Shevket,
20.
if you look at the proximal
20,
part of the LED
down,
where
yeah.
most of the calcium is, he actually has 3 wires. So even an NC will work like a scoring balloon here because
3.5,
you can have
15.
2 other wires around it. So
Yeah.
it might work as a
20.
scoring balloon.
20.
Yeah, poor man's
20.
scoring balloon.
Always.
Yeah. Sort of. Poor man's squirmy.
Right.
And he already said he's not ready.
Wow.
Yeah,
Ruptured.
No problem.
What time? What is it? So 3 or ruptured at 20, right?
Yes.
Okay.
Yeah, this is a good sign.
No problem.
That's okay.
This
no
is a
problem.
good sign that you need more plug modification.
Yeah.
So that was the reason why I wanted to see the iris after rota. Maybe we would have go directly with the scoring balloon before the NC. This talk is just for educational purposes, you know. So I'm not suggesting anything, but
Balloon.
it would be, we have the iris on table.
Balloon.
Why not going in there with the iris and see it after the rotablation?
O niye?
But now it's too late. We can do it anyway.
Did you ask any question, Şevket? I couldn't
No,
follow.
I'm just blabbing around.
Okay. Which mood are you today?
Keep working, keep working. I'm in a good mood.
Okay.
I'm always in a good mood. When I see you working, I'm always happy. Seeing such a
Thank you
giant
very much.
interventional cardiologist
Oh, come on.
working and learning from him, it's always good.
Yes.
Okay, go up. This is 3.5. Yeah, go up. Yeah, okay. Yeah.
You see, the balloon is going
Yeah.
around the calcium. So
Yes.
I
So-
think that's a sign of deep calcium. So that might be the reason why I wanted to use here a scoring or a cutting balloon.
Yes, go up.
Oh, I might use cutting balloon here.
Yeah, cutting balloon probably.
If it's now open.
No, good opening. No.
What do you think? Is okay? Not
Yes,
sure. Not sure.
This
to me.
part good, but the proximal part needs some kind
Not
of
sure.
more
Try
modification.
it again.
Yeah,
Yeah.
That's
go
where
ahead.
most of the calcium was on iris.
Yeah.
Okay. Yeah.
20.
But we skipped that part already.
No,
there's
I
still
think
something-
I'll do cutting here.
Yeah, cutting would be better.
20. Cutting.
Thank God you are getting richer and richer.
Cutting.
Yeah, I
Proximal
know.
opening is
First
good.
NC quantum, now cutting balloon.
Or scoring. Cutting or scoring.
I think
This is a Boston session,
Okay,
so we
yeah.
are gonna do a Wolverine, I think. They don't have the
Which
scoring
buçuk?
balloons.
Yeah, I think
Okay. Yeah.
sort of
No, no.
scoring.
Cutting.
Altı çok çok.
Okay. 6 is okay.
Yes.
Yeah,
maybe.
Six is okay.
Yeah,
Yes,
3.5, 6,
By
we
six,
have
yeah.
flex tone cutting.
No Wolverine?
Not today, I think. Mostly we use, but this is
Oh
also
my.
quite good for me.
My camera is committed suicide, so I'm not on the screen anymore.
But I think, guys, it's important to see that part is not that opened well, right? It's this
Yeah.
is important.
Right, there's a bit of a waste. It's
Yeah,
just-
yeah. That's why I like to touch by 3.5, Rasha. You know, if I would go directly stand after 3,
Yes.
I wouldn't
Not
see
good,
that.
expansion.
Right, you're right.
But it's
And also in terms of sizing your cutting balloon, like you knew the vessel size was around 4, so probably 0.5 smaller will prevent
Yeah.
any major dissection. So
Yes,
probably
good.
great sizing.
let's
It's much
Yes,
sure,
yes,
maybe it's a still wire LED one.
here. Okay, go up here.
We have to do something for the arguments.
Yeah, that's okay.
More?
14. 10.
this is also
10.
interesting to
Go up
see.
to 10.
We have a wire there, and we are
10, yeah?
cutting
You can go.
also
12.
the wire somehow.
Do you think so? It's possible?
Yes.
I don't know. We will see.
Yes, now it's
what's
okay, huh?
interesting is
Is
with
it
IVL,
okay?
we can
It looks
make
okay.
Yes.
Down.
wide, and it wouldn't
Ay,
affect this. I wonder if it's
hemşiresi
okay.
başında.
Maybe from diagonal.
12, 14. Yeah, we need to have
Yes, yes.
pain, huh?
Yes.
The ideal option is always off.
Yeah.
off
I
the
think we
table
are
for
okay
me,
here,
so-
right, guys?
Yeah. This is good.
Kaç yaptın?
40.
Okay, let's see. I think it's okay now.
I think more proximal we should do it also. You see the proximal part?
Yes,
It needs
definitely.
also.
Yeah,
It needs also modification.
But you
the
see,
proximal part.
I'm losing diagonal. Maybe we have hematoma,
Rupture.
hematoma there.
Yes.
I think more than plaque shifting, we might have hematoma, after dissection. we have to take care of the diagonal, and I think we will stand that.
And so on.
And my stack technique will be crush rather than
Yes, yes. We need to do something.
Yeah.
Diagonal first.
uh,
I am craving for seeing the IVUS now.
Normal tel problem.
2.5 and C for
3.75
the
var.
diagonal scheme. What are you going to do?
3.75 and C.
You can do a nano crush for that diagonal,
3.75 and C.
just with a balloon in the LED.
Ömer also likes nano crush.
So guys, I like to touch with the 3.75 with that lesion once more, and I go diagonal. What do you think?
Diagonal first, yeah. You should definitely balloon the diagonal first.
Yeah, balloon it first because there's no flow there. It's probably
All right, okay,
let's.
give me 2.5
Yes.
balloon.
Balon.
And C, yeah.
2.5 balon.
Yeah. 2.5, yeah?
Yes, yes.
2.5 balloon, yeah?
Once you deal with the
2.5,
diagonal, if you have-
15.
No. This
once you deal with that diagonal, see if you have time to show us an IVUS run. If you put all of this to the calcium.
normal.
Hadi o çabuk.
And C.
Çabuk var. It's big diagonal, huh?
It is, yeah.
Large
Just like
territory.
a 2.75 or 3.
Yeah, of course. Normally I like to do clot, but I don't want to do clot because I did already ballooning. I might have dissection, so I can't recross the lesion again, the LED lesion. So I prefer, yes, go up.
Go up.
Let's see. 10, 12. Okay, him. 12. Down.
Yes,
Bir filme gidelim.
let's see.
So it looks long lesion, right, guys?
Yeah.
Yes, more distant.
Maybe balloon a bit distant.
I don't like the feeling of the LED.
Yeah.
Okay, go up here.
Go up.
I think we have to be a little bit, hurry.
Quick, yeah, maybe
Right.
start
Yeah,
standing.
down, yeah.
But with the calcification,
Up and
I
down.
feel a bit more safe than without calcification. You
Down.
have some kind
Down.
of skeleton
Let's measure it.
around
Let's
the
measure it.
vessel. So it might to give you an opportunity to go out
Okay,
there
got-
without stanting, maybe.
Okay.
Okay,
So,
okay.
how,
This is 15.
15, 28,
Yes,
this will be fine.
23 or
28.
Yeah, would you
yes.
stand that diagonal?
Yeah, I will do it. Yeah.
Nihat, what do you think? Nihat would leave it
No,
without stamping.
no, I don't think so. I can't lose this diagonal.
Yes,
Yeah, no, it's already.
I don't know what's happening there. I think I have a dissection because it's enlarged
yes,
a little
sure.
bit.
Right.
Uh,
It seems like the haziness.
2.5.
left in-
Yeah.
It's so 275 or
Bit of hematoma, yeah.
2.5, and then we can increase it, huh?
You'll do crush, yeah?
We will do
Crush.
crush.
Yes.
So this is going to be rota and then
28.
a vessel pacing
Scoopy.
case.
28.
Definitely complex.
Okay, go up here. This is, yeah,
Go
14. This is
375?
375. 20, 24. 24.
Yes, yes, enough. Yeah.
I think that's fine.
Yeah,
That's
yeah.
fine, guys. I don't know.
We have some curve here.
Down? What do you think?
Looks better. Looks better.
Looks acceptable, yeah.
Yeah. Better.
20.
Much better.
Go up.
20. 20.
Wait.
Down. Okay. I like to have 2.5, and I will go with the 275 by post dilatation. What do you think? 2.5. Yeah, I will keep it here. Yeah,
Yes, yes,
2.5.
275.
Negative.
No.
So the stand in the diet.
No, I think
This
we can
LED.
put
This
2.5,
diagonal.
2.5,
Yes.
and we can go.
Go with.
Just a second. We can go with. Let's see again. Can I give? Yes. Can I have some nitro, guys?
Yes,
But
we
pressure
can
is
do.
okay.
Everything is okay.
We have dissection for sure. So tell me 275 or I think 2.5 is good. Then I will extend it 275 anyway.
Yes, yes.
33 kaç?
38 or something.
Yok yok 28 diagonal için.
Yeah.
28 yeter.
Sure.
For distance.
Balon kaçtı arkadaşlar?
15. 15
2,5-28 ver bana.
28. 2,5-28. Yes.
You'll cover down to the first curve in that diagonal.
No,
right?
this is the LED wire. Here.
All right. This is the diagonal, right?
Yes, this is the
Fluoro.
diagonal.
Okay.
this is the
Send it,
diagonal.
please.
Yes.
So obviously this is complex lesion. You see that we have issue with the diagonal. We didn't touch it, but still we have issue. It could happen. And our ACT is good because it was 300 and we give 2,000 more.
Ufak.
Oh, all right.
So you have 3 wires. I think you should pull the first diagonal wire.
I want to see the
The
stand.
wires
Fluoro?
are entangled.
It's a small diet.
Yeah.
Okay, I'm not
We
sure.
are in the circle stand.
No, I'm in the right position. No. But I have this one.
Yes, yes. This is diagonal.
This diagonal first.
The
But
proximal part of the LED is still calcified, and it hinders the stand go smoothly through the lesion.
not easy to
And-
pull. I have to be careful regarding pulling my.
Ah.
Yeah.
Yes. They are out.
And I have some deformation at the proximal part, maybe. So
I think the problem
let's
from
insert-
the circle stand.
yeah, let's do something.
Mm.
Let's insert this first, if we could.
Maybe you need a balloon, small balloon.
I'll probably maybe take a balloon with a guide liner, try to go beyond that circ,
Negative. Yes.
also interference
Yes,
with
yes.
it.
All right.
It's coming.
If I insert this,
Oh.
which is not easy, this is big balloon.
Yeah.
I like to anchor it.
Yeah.
I'm
Yeah.
afraid that I lose the stand because the proximal part, it happens to me some time ago. Which is stand?
Stand is here.
Can you retrieve the first diagonal wire? It will help you.
No, I mean, now my issue is pulling stand into the guiding, Şevket.
Oh, you can't do that now. Oh.
Because I have, I have
No,
issue.
Yes.
Okay.
You see?
Yeah, this is.
Hey,
Aynısı oldu. Niye bunu
Back
verdin?
into the guide now, huh?
Sorry, no.
It's not.
Göster box'unu.
Let's see if the stand is okay. 30'a gel.
Yes, stand in the position.
It's okay.
Yes,
Let's
it's
see.
okay.
Are you sure? But why? Okay, let's see.
Still
Let's
on
see.
the balloon
Let's see.
at least.
If you can do that, maybe you have to pin your balloon to the stand and then remove the whole system. That would be safe, I
Yes, this
think.
panel.
It's
Let's
not. It's a bad option, but
Let's
It's
see.
safe one.
Let's see. I'm happy if I remove this stand,
yeah.
which I don't know. Let's see.
Let it
It's
move.
already in.
Sure. No, I don't think so. It's
It is
here.
here. It is here. We need to remove everything now.
It's
Yeah,
okay.
yeah. Do it. The safe way is
But,
important.
it will be
Pin the balloon to the stand, and then remove the whole system.
small balloon in the stand.
All right. The good thing,
Nihat has always some solutions for such kind of things. Nihat, what do you think? What should we do?
you know, everything, guys, everything happens on your, front of your eyes. I didn't push that much. When I feel it's not crossing, I try to pull it, and I don't know why it happened.
What's the brand of the stand?
It is distally. It is not in the guiding.
The stand is on the wire now, and it's outside the guiding catheter.
Yes.
Wow.
So the best option to
Snaring,
have
maybe
snaring from the
Yeah.
from the
other wire.
proximal.
Come back. Back.
But first of all, I like to treat the vessel.
No,
Okay.
It will stay.
You want
I-
to push the wire in a bit? So it
No, it's okay.
stays on the
Touch.
wire?
So let's. Yeah,
Yes.
I can have it. I don't think I can have it in my sheath.
Yes,
Right.
that is a problem. Yeah.
It's already damaged. So what we do? I can snare it from here.
Yeah. You should snare it.
And yeah, let's
This is
lay it
small.
from here, okay? It's a big
What's the brand of the
hangisi
stand?
hangisi?
Zymes? Promus?
No,
What
It's
is
the
it?
Biomatrix.
Biomatrix.
Öteki hangisi?
This can happen also to a very renowned operator.
Stuck
As
on
you
the
see.
wire. That's a good thing.
All
Yeah.
right. So let's have a snare.
So we are so relieved that
Küçük loop.
when this happens, we will not regret it. Ömer, when this happens to us, then we will not regret it. Even Ömer did this, even in a live case.
No,
where-
but no. It happens on your eyes, okay?
Yeah.
Front of your eyes. I don't think we did that much aggressive
No.
behavior. So
It's not on you. It's not on you.
no. I mean, it could. Yeah, sometimes I could force more, but I didn't. I'm saying that. You know. So listen.
En küçük. Ha.
I think the third wire was entangled with the other wires. And by
No, it's
pushing-
not. It's not the issue. It didn't cross. Maybe there is twisting, but I could pull it back nicely, right? So actually, it happens to me some time ago.
Me either.
Do you have it?
Yeah, of course. Everyone had it.
Yeah.
No one confess it.
The good thing is you can still see it.
Yeah.
Sometimes you can't see it.
So
But
I
that's the
said,
best part. If you can't see it, then the problem is solved. Okay?
Done.
There's no problem. But now you have to struggle.
And how far is your wire? Is it up 10? Probably struggling with getting
Eğer istersen tel içinde
Geri gel.
I had the stent in the radial artery, so I had to puncture the ulnar artery and then go from the retrograde to the radial artery and had to pull it from the ulnar artery into the sheath. It happened once to me.
All right. Scoop.
But
Göstersene.
now you are in the brachial artery. You are luckier than me, I think.
Now in the axillary artery, I think.
Yeah.
First now. Okay.
It is coming. That's it.
I don't think. Not
Be
easy.
careful because the wire might be off of the stent at this point.
All right.
Uh-oh. I think you're losing the stent. It's coming closer to the tip now.
That's okay.
Yes, okay.
We should do it the other way around.
Yes. Keep.
No, it's not a problem.
Oh, it's going
Let us remove
forward.
this for you. Yes.
Yeah.
No, it's coming with the flow.
With,
I will catch from maybe
got
other
it.
side.
Yes.
Yeah,
Now is
I did it.
Okay.
I think
Let's
I
go.
could. Yeah,
Okay,
okay.
Big applause.
Guide it.
Yeah. Let's have it.
Excellent. You got it.
It's
Yes,
here.
It is here.
We catch it. All right. Let's go. Start the game again. Fire.
Tel. 35 tel.
The final chef got some excitement.
Yeah. I'm very happy.
Stand.
So since I lose
Looking
my
like a very dull case.
since I lose my diagonal wire, let's do cloth. Or no, let's do crash again, huh?
Yes.
Crash.
For me, the diagonal is not a big issue. So maybe we can even try to do a jailing balloon there. I know you want to stand it, but it's going. We have so much work to do now. We have to deal with the proximal part of the LID,
Hold on.
and the diagonal is not a big issue now.
Okay. Yeah, test please. Test. So can you tell me the ACT, guys? How much the ACT?
Okay.
ACT is important, yeah.
I think it depends on what it looks now.
Test please.
I think that the diagonal is open. I don't think it's
Okay.
it's
Ayıp
gonna be
cranial.
a problem.
Spider please.
Spider.
Tel. Kızım buraya konsantre ol.
BMW tel.
Tel.
Tel.
Şey. Buraya
İyi tel.
konsantre
İyi
ol.
tel ihtiyaç var.
Hamza Haşim.
Evet, give him an expensive wire.
I will see you. Oh, we have some. No.
What?
No problem.
You see the diagonal is good?
Yeah.
Oh,
You can
wow,
see
wow,
all
wow.
in the
What?
LED.
Yes,
Yeah.
we know there is a proximal LED.
Of course, there will be dissection, guys. What are you
Yeah,
thinking
yeah.
about?
Yeah, of course, of
Probably
course.
secure the LED. I think bag we can deal with it here.
Yeah.
Of course,
Yeah.
there could be.
Bu iyi tel mi?
Make sure your wire is luminal.
I'll
Yeah,
do
exactly. Fix
I
the LED in that.
bu sörke gider. Bir tane daha tel verin.
Tel,
Fresh.
iyi tel, iyi tel.
Fresh.
iyi tel, hadi.
Yeni.
E-tel means expensive wire in Turkish. E-tel, expensive wire.
So just one suggestion, do you want to
İyi mi
consider
hocam?
giving some agrostat bolus here, like maybe that might
Evet,
help?
yes sir. Kavdaga.
AP code.
Esat, I don't think it will help here. It's not class. It's
Yeah, but
calcification.
it's dissected, so if there is delay in wiring,
Bu çok mantıklı.
I don't know.
Yeah.
Just a bolus.
Diğer telden de alalım. BMW'de de alalım. The first, let's focus on the LED first, right?
Agreed.
Yes.
Yeah.
How's
Yes,
the
I
patient
agree.
doing clinically?
I can regain diagonal. I can regain diagonal if something happened.
Yeah, afterwards,
Yeah.
after
Alright.
the LED.
I'm lucky that I can cross diagonal. Okay, another wire. This is go to diagonal,
Oh, good.
which is okay.
Yes.
Bir tane daha tel alayım.
Tel.
BMW.
BMW oldu mu?
BMW.
Distally, I like to put say trio balloon, trio stands approximately 3.5, and I will expand 3.540.
Why didn't you use
Burada-
the circ wire to put it back into the LED? That way you don't have too many wires.
Say again?
Do you want to use your circ wire back into the LED now instead of a third wire?
The circ wire?
You have another wire in the circ now.
Yeah, I like
Yes,
to
yes.
have it
Three wires,
because
yeah.
I
Biraz
don't want to go
torque,
deep
torque.
engagement first, and second,
Yok yok dört kastı
I don't. If something happens to LED, I don't want to lose circ as well. So let's keep circ.
Cranial.
Because we
Good
have
fire.
some kind of dissection there and we
Yeah, it might go
injected the
easily
rock,
to-
so
it
the
might go
hematoma
easily.
may go backwards and
Good.
it will
Okay,
cause some
now
kind
we
of-
back to the work, guys. That's okay. Let's see one shot,
Yes, what's
please.
wrong,
Yeah, and then see.
Beautiful.
Yes,
All right.
we are
Definitely, we have to take care of the diagonal.
Yes, let us
Let's
go
do
on the same
diagonal.
plane, huh?
Even I
28 tamam mı?
I think we fix the lower one and then
Yeah,
Ya da
yeah.
28 olur mu?
28,
leave the
evet,
upper
evet.
bag.
Rizal.
We have a big
Result.
circle where
Tamam,
we have
28,
diagonal.
28, 30
Tamam
alalım.
ya.
Maybe suggest maybe using a shorter stance, 2 stents instead of 1 long.
No, it's okay, it's okay. So I don't think I have a twist now, Rasha, because I crossed the LED, the latest. So that's okay, I think. I don't think I twist them. When I tried to go, especially for maybe, it was easy to cross both art diagonal. I didn't play that much. I don't think I have a twisting anyway. But now I don't think we have issue here. We will have issue. Let's see, of
Bu
course.
LED, bu LED. Ha.
It's LED.
Yes, yes, yes, yes.
All right.
The pressure is good, the patient has no pain.
No, pressure
No,
is
no,
good.
pressure-
Do you see
it's
the
stable.
pressure? Pressure is good. Pressure is
Pressure is good and pressure is stable.
140.
Yes.
The LED is there anyway.
This is the argument.
So we have a lot of time, so you
the
can
other.
walk in peace.
Yes,
don't-
yes, of course.
Have to go very swiftly. So we don't have any more presentations left, so sorry for that, but we will keep talking.
Basıncı gösterecekti de. Geçti.
Okay, I have.
Yeah.
I mean,
You need the guide liner or an anchoring balloon.
anchoring balloon much be better. Okay, 3.5 short balloon.
Short balloon. Uç
So
sıfır.
you have a standard segment in your circs, maybe put your balloon there.
12.
3,5 mu?
3.5 12. Okay, let's do anchoring because I have lots of wire. You know, I have to remove. Aç. But it's real life, yeah. I need this anyway for crash.
Yeah, fair enough.
Ömer is always a fan of anchoring balloon, and I'm a fan of Godzilla or Guideline or something like that. I am the expensive guy. He is the poor guy. So
Slowly, slowly.
Yeah, they're extremely useful in cases like this where you're
Yeah, but yeah.
confident.
All right. So let's remove bir tane daha alayım balon.
3,5-8 bir tane daha arkadaşlar.
I like to remove my course. So right. I think guys I use Guideliner here. Godzilla. Do you have Godzilla?
of course, Boston is there.
Remove the stent and we will.
Ankara'sı.
Or we can
Ömer, would you consider that part again, ballooning with the
Anchor
cutting
stent
balloon
is
at
better
that part? We didn't have a cutting balloon at that part, you
Service
know?
alone here.
The part, yeah, the part where you are now trying to go with your
Kaç
stent,
bu?
this part has not been ballooned with the cutting balloon.
But I think there's a significant dissection too in that proximal.
Yeah, of course, there is dissection, but the calcification is also coming in the way, so you cannot push it. We need a smooth way, a smooth.
You know,
moving
there
way.
is lots of calcification and we break the calcification. That's why it's not easy to insert stents. That's the reason.
Yeah, but my suggestion is to go with the modification further, because if you even go with the
Remove the stent
anchoring
before.
balloon there, you have the risk of losing the stent inside the lesion. So my suggestion is going with the modification further.
We definitely
you
go
having-
with Godzilla.
Godzilla.
You're having trouble pulling back on the stent? No?
And there will be also an issue with three wires with the Godzilla. And the Godzilla will also be very tricky to go through the calcification. It might increase the dissection and even cause perforation. So I would definitely go first with more modification before going with the Godzilla or Guideliner there.
Bozuldu. Tamam mı?
Bozuldu mu? Evet.
Bozuldu bu.
Hocam stent soyuldu. 7 alalım mı Kayseri'yi?
6.
6 Kayseri'den.
6. This is LED, yeah?
This is diagonal.
This is diagonal
Yes.
LED.
Yes.
Are you going to pull the wires out or just the three wires in the Godzilla?
Guys, what I
together?
do,
I think you should remove your CX and diagonal wire. And
That-
then
I will remove CX.
again that part before sanding the stand. It's safer. Because
so we go
if you cannot go with the guideliner in, you may need again some kind
we will
of
do cloth. Okay?
modification with the ballooning. We should do it beforehand, before introducing the guideliner at that lesion, at that calcified,
Stent as well.
dissected lesion.
Başka stent.
Because if you even go giving contrast from the guideliner, the pressure of the contrast is high with the guideliner, so you might increase the. You see what I mean?
2,5 kısa balon alayım.
Balon.
I would advance it with the balloon ahead. I think it's better to.
Masadaki
Yeah.
3,5.
Evet.
Yeah,
15
we
mi?
do.
Daha kısa yok mu? It's long one.
The guideliner will only shorten the calcified length of the artery now.
Asete sayıyor mu?
It's coming back.
Tamam.
Okay, 12, 14, 16. Down. It's really complex case, huh?
Yeah.
10,
Way
12.
harder than what it
14.
looks.
14.
But angiographically speaking, I would definitely go, even if I didn't have any kind of, I would definitely go with the
Stent.
Rota in this
Stent.
case.
Stent.
Hazır.
You have that typical cramp track
Leave, huh?
within
Hadi baba.
Yeah.
approximately a lot of gap. Oh, great. So we've got the guideline.
Evet hocam. Tamam 2000 efendim ekleyeceğiz.
Tamam.
Tamam
Öz-
biliyorum çok zaman geçti.
Yok tekrar şey alalım. Çok derin yaptık.
LCT, yeah.
Toplamda 15 gün oldu.
Bu nedir?
Stent.
Sen 2,5-30.
3,5 gansi hazırlayın bana, gibi olsun.
Kendisi hazır.
Now I'll do cloth, guys, here. Cloth, okay?
What size stent are you using now?
3.530.
2.5.
2.5.
Yes.
Yeah, 2.5.
Yes.
Sorry. Yeah.
Yes, remove.
All right. Let's see. Small injection, not
Yes,
much.
Yes.
We have dissection there. Very gently. Very gently. All right. All right. This is nice.
Yes.
2, 4, 6,
Yes.
10, 12.
Stand.
2, 4, 12.
Because
Mini clot.
I do minicot, yeah.
Yes, yes.
Yeah.
So go up more.
Okay.
Go 18.
18, yes.
18.
Yes, good opening.
Okay. Show me there. I don't like the proximal part. Göstersene bu. Sine
Önce.
miydi bu? Sineği göster. Öncekine gel.
Önceki gel.
Balona gel.
En son.
The proximal,
Yeah.
what do you think?
It's not opening.
Okay.
Go up.
2.5.
Yeah.
Do you want to take an
Which
NC
buçuk
first?
NC?
Yeah. 3.5 for pot, yeah? No, 3.75.
3.75. NC. Tamam. Fark.
It's very frustrating when somebody is talking around and if you are walking, but Ömer is very used to it, so I think he will not be
3.75.
angry with us
Masadaki.
Ver.
İyi mi?
İyi durumda
İyi
ama
if I am not teasing him.
What did you say? I didn't hear you. What did you say?
You are doing a very good job. That's what I am saying.
You know, I have lots of problems because you said lots of good things to me. That's why I had these issues.
Yeah.
Yes. Test,
Yayını kapatabilir miyim? Bir saniye.
test, please. All right.
Yes, good. Yeah.
I do. Yeah. Okay. Go up.
Go,
10,
go.
14. 14.
2,
14.
14.
20.
But good opening. not
That's
bad.
okay. Opening is okay. Down.
Yeah.
Hocam asetamol yazılacak mı?
Tekrar
All right. So what we do, what I want to do, I'll remove this diagonal, and I'll like to across it with this wire. So I hope I can do it, inshallah, and then I'll have a nice way to go down. Torque, please. Torque. Ne yaptın ki?
Hep
Burası
bakalım.
açık, baktın mı?
Baktın
Evet,
mı?
eliniz
Peki, tamam.
üstünde zaten kapalı.
Tamam, distal benim.
Kanun sıfırlar.
Alright. Bir 2-0 balon alabilir miyim?
Ne 2-0?
I like to use a balloon here for sport. I think this wire is kinked and needs balloon. But I want to free, yes.
Good, these two. Go.
But I shouldn't go that way. I should go easily to distal. Test,
Probably
please.
use a fresh wire. I think we've got a lot of curves.
Yeah.
All right. That's okay. I have LAD.
Yes, yes, LED is
No
not
problem.
difficult.
No rush. Bir tane
Leave tell. Proximal göster şeye.
or I have still chance to go maybe crush. You know, I have a wire in place.
İzotonik alabilir miyiz?
Not
Fine,
use
it.
the process.
Yeah, crash might be also a good option.
If I have to. If I have
Proximal.
to.
Proximal.
Proximally göster. So when you try to proximally gösterir misin? When you try to in Godzilla, you have to see the proximal part that you have to make sure you are in.
Right.
Talk, please. Sometimes it's tricky. I know.
Yes.
I mean, I
Good.
think. Let's see. Okay.
Yes.
2-0 balon istiyorum.
Yes.
That's important that I follow the true lumen. I
Yes.
might have easily. That's why we shouldn't use here hydrophilic wire. All right.
Yes, yes.
Very nice.
Yes.
2-0 balon.
2-0 balon alalım.
Sonra 3-0 mı?
Evet.
Let's do 3.5 and
3-0 distal yaptık hocam.
2.75. Alright. But normally I do
Evet. 3
normally I do double cloth, kissing cloth, but here I don't do it, you know. I don't want to make it
this wire.
more complex.
Yes.
I remove the jail one.
Yes.
I can do it. I can send another wire. 12-14.
On 4.
6-0 elinden alabilirim.
16-18-20.
Yeah.
İn.
3-0.
3.5.
8 masada var Nil.
Tamam. Yok masada.
Ver bana. So first I like to have trio
3,5-8 Nil.
trio 28 and then 3.5. I like to put the first stand under
Negative.
diagonal, below the diagonal, sorry. Yes, go up 12, 12,
12.
down.
Now the size of stand.
Yeah. Buraya up 20. 3.28. So
12. 12.
28. Down.
Down.
3.28.
Stand. Dikkat edin.
Hayır.
Stand. Evet. Oh, stand tamam.
İyi kapama imkanı.
Okay.
Russia, only the two of us left?
Still around. No more excitement. No trapped stunts or
It's enough.
he's making it look easy now. It's a tough case. These are the cases that if you don't plan ahead, you can get into trouble. So making sure you have all the equipments in the lab.
Let's see if I hit.
If you are not an experienced operator, you can look at the angio and say that I am good, I am cracked with non-compliant balloon. But if you're an experienced operator, you will understand how difficult it can be. So then you plan accordingly.
More.
Here. Yeah.
Yes, here.
Okay, up here, 14.
12.
And we have to make
12.
Yes, good.
14
14.
down. So let's make a measurement first.
I think
Apicaudal,
48.
I will cover left main, right, guys?
Yes.
Okay, test.
This is 20 years, 48, not enough.
I need
maybe.
48. Yeah, 48 will be fine. No?
Yes. Maybe.
Let's put 48,
Yes,
3.5.
From elde distal, yes.
Okay.
3.5 48 alalım.
But I like to insert a little bit more my Godzilla. No one knows
Yes.
what will happen like this. Aç.
Yeah, I agree. I think longer stunts to make sure you have enough room for pots if you need to go back to the circ. All of this will.
That's okay. Az kaldı. So
So Russia, are we gonna leave in 4 minutes? Is it the case?
We have until 6 o'clock, so hopefully we'll see at least this delivery of the stunt.
Yeah. There are 4 minutes. 4 minutes to go.
4 minutes, correct.
you don't want to see
Yes,
the
this side is
results?
Okay now. No,
Yeah, but I have a plane to catch.
You can go.
Yeah, I will do it.
Yes, this side is okay. 1 milli this side, 1 milli.
You might miss excitement again.
Apicaudal. Apicaudal.
Go down.
Maybe without me it will be much smoother. It will be smoother.
Test please. That's okay. I
Yes.
cover it.
Yes.
I like it.
Go up.
12.
Yes, yes.
You
14.
have enough overlap there?
Yeah, I did.
We don't have.
I hope.
The circle. No problem.
I think we did, yes.
12.
12, 14, 16.
Looks really nicely expanded
Down.
here. So this
Yes.
tells you you've done a good
Bring
way.
attention
Good.
So I like to have now, guys, 5-0 balloon for
5-0 balon.
pots, and then
5-0-8 10.
I
Go to
recross
diagonal again.
diagonal, the circle. But I do it later. First, let's do pot at the
Yes.
left main. And I can remove, I think, my Godlaner, Godzilla too.
Yeah, that will make it simpler.
Not sure if we can extend this a few more minutes. If we can't, it would be great to see an IVIS to see how.
You can give, if you give me 15 minutes, I can
Remove
show everything. 15 minutes, I think from now
5-0
would be
balon.
enough. Ver. ACT kaç?
Aslında 2000, hayır
Evet.
8 dakika önce 2000 ekledim.
Everything
Okay, you see that how much Godzilla helpful, extension guiding helpful for us. Without Godzilla, I don't think we could do this. Because the reason is, we break the calcium. There are lots of calcium and plaque. You know, they block our way to go down.
Right.
It doesn't mean that we didn't open it nice. I
AST
think
alalım.
Alacağım hocam.
we had dissection
Yes.
there.
AST veriyorlar.
I pick test please.
Yes. AST
Okay, this is the
check.
5-0.
Test.
Yes, we need AST.
Okay, let's see. Pressure is okay, 140 again. Okay, let's do here. Yeah, go up here.
Yes.
10. Down.
More distal.
I should have to go more distal right. And I'm happy that the circ is
Hiding.
Yes, go
stent
up.
is covered osteum. Test.
Yes, here is okay.
Yeah, it's
Go up.
here is good.
Go up.
Yeah, go
Go
up.
up.
Yeah. 10, 12.
12.
Okay. All right. At the end, I recross and I'll do kissing for sure for circ. But
Let's
let's
see
let's
cranial
focus on the
Diagonal and LED.
recross the diagonal,
Yeah.
do kiss and then do pot all the way.
Let us see here both and the cranial one.
Okay. See here.
Circ is okay.
Okay.
Cranial.
Now we
Nice.
seal the dissection.
Calling on it.
Everything is
LED looks okay.
Yes. And diagonal okay.
And opening is not that big much bad.
Yes.
That part.
Tell.
LED looks beautiful. Very good.
Yeah,
shape.
and we do 275 for diagonal, okay? For post for
Yes. Tell.
yeah, 3 will be big, 2.5 small. Okay, let's have another
Wire.
wire and 2 balloon. And 3, I need first 3 balloon.
We've got 15 minutes more. So
Oh,
hopefully we'll
okay.
get to the end of this so you can finish.
Okay, inshallah we'll do our best. So this wire is used wire, not fresh one. It may take time a little bit to cross. That's why I'm saying that. Okay.
Nice. İki sıfır balon.
Hazır.
Okay. Now 2.0 balloon and
2-0-12.
Rasha, do I have the permission
Sıfır
to
balon
leave
isteyeceğim.
because it's time up for me.
Yeah, no problem. We
Okay,
extended
okay.
15 minutes, so we'll
Okay.
see.
Yeah, he will do it nicely.
So
Ömer, congratulations for the case. It was a nice demonstration. We have learned again
Yes, go
something
up.
for you. Thank you very
thank
much.
you very much. Thank you.
Thank-
Thank you, Şevket, for your help and comment. Thank you very much.
Go up.
çalışıyor mu? Ah,
Yeah. Okay, down.
Down.
Okay,
Şimdi
275
2.75
for diagonal and
or 3.75.
yeah, normally 3.5,
3.5 is enough.
but
for-
distally 3.0, yeah?
yes,
what
yes,
do you think?
Exactly, yes.
Yeah? So guys, distally, do you like to have, let's see its eyes and tell me if I can go 3.5 all the way.
Yeah, maybe high
According
pressure.
to
on
Ivers,
2.5.
it was 3.
But yeah,
Maybe we need.
I think we can do 3.5
yes.
that part. What do you think?
You're talking about the diagonal or talking about the LAD?
Yeah.
The LAD, the distal LAD I mean.
Oh, I see.
Bu ne bu?
Bu 2.75 diagonal. 2.75 diagonal.
Maybe low pressure on the 3.5.
Yeah, I agree.
Then high pressure proximal.
Gently, nicely, yeah.
Gently, yeah, exactly.
3.75. 3.75.
Just 10, 12.
Tamam. Yok 3.75. 3.5.
Hazır 3.5.
Yes, good.
3.5 veriyorum.
So this is the 2.5?
275.
2.75.
Bu kaç bu?
3.5. 3.5.
Buradan geçer mi?
Yes.
Burada 100.
Yes.
Geçti.
Yes.
Okay, let's do gentle.
Yes.
Go to 8 and later 10, okay?
Daha var hocam.
Dirsel,
liste,
more dirsel.
var.
30 aga. Yes, it is enough. No, yes.
It's here.
Yes, here it is enough. Yes. Go up.
Let's do small,
8.
slowly. 8.
6,
Obviously.
8,
Okay, 10.
10,
Yes, it is enough.
Stay. Down. Let's
Down.
see. It's became bigger. Let's see what happened.
Go
Go up here.
Yes.
10.
10,
Down.
Good here, but the box.
But easily expand. I don't like it that
Yes,
much.
here. Go up
Ağrısı.
10, 12, 10,
because we have two balloons. No
10,
balloon.
10,
12,
12, yeah. 12.
14.
14,
It's okay.
Yes,
It's okay.
now it's okay.
Down. Yeah. Let's do kissing and let's
Yeah.
see the result.
kaç? Ha?
Yes.
Test. I like to see the.
Distal?
Yeah, because we do
Yeah.
post dilatation of.
No problem.
All right.
No problem.
LAD looks okay. We are very happy that we don't have rupture here.
Let us do
So,
distal brigadier.
Hopefully we don't have
Yeah.
for diagonal too.
Yes, here is okay.
Yeah.
Yes.
Okay. 12.
12.
Okay. Okay.
Şey yapmazsa devam
Okay. 14.
14. Yeah.
16.
16.
Down.
It's enough.
Okay. 16.
Yes.
Down.
Tamam. LAD.
20. This is
Önce sen
go 20.
Yes.
We go 20 here.
20.
Down.
Yes.
So in vitro studies
Kissing.
say that opening a
12.
cell
Yeah,
strut
you have to go
works
to
best if you go up to at least 18. So yeah, 20 makes perfect
6,
sense.
6, 8,
8,
10,
10,
12,
12, 1,
bekle.
2,
4.
ben yanlış şey düşündüm.
2, 4. Direkt.
Well, diagonal.
Okay.
They didn't do the simultaneous kissing, so I asked them again.
4,
4,
6,
6,
8,
10,
10,
12.
12,
1, 2, 3,
Bir.
down. Okay, let's see what we have here. And I will do 4-0 for the proximal part, okay?
4-0 hensi hazırla.
After recrossing, 4-0 and 3.5 kissing, 4-0 kissing. Test, please.
So maybe we can keep that balloon there, no? You wanna do KBI and with the circ as well, so keep the balloon on the wire on the LED. Then just
Okay, this is good.
Very nice.
Okay, okay.
Yeah.
We can do 4-0.
4-0, I will do
Yes, yes,
4-0.
yes.
Yeah, LED looks great. So
Yeah.
diagonal.
We open, yeah, we break everything there.
4-0 balon.
4-0.
So your plan is to go
Is
with a
ready?
bigger balloon.
4-0 for the
proximal.
proximal, and I'll go with this wire with the circ.
Gavdan,
Spider.
gavdan.
Ekleyelim mi?
Evet, evet.
260.
200.
Ekleyin. Hı hı.
Evet, evet, evet.
Y.
Okay. 4-0, 3.5, okay?
Hocam Y kapatır mısınız? Kapalı.
For all.
Kapalı.
4-0.
Yep.
This
Yes, yes.
Yok,
This one.
kapalı.
3.5.
Heparin eklendi.
Tamam.
Timer eklediniz.
Cranial get. Cranial. Önce cranial.
We can see the.
Yes,
Yeah.
yes.
4-0 falan.
Let us see here. Yes, exactly.
Let's do it here,
Yes,
right?
yeah.
Okay.
No.
10, 14.
10, 12,
This is the most
Ten.
difficult part.
14.
Kaç?
Yeah.
Okay, down.
Üç buçuk.
14, 16. 3.5 ver bana.
Hazır.
16.
Ver. Niv değil mi bu?
Yok hocam masada değil. Kim alayım mı?
Okay, that's okay.
Bakalım.
3.5 kaç bir indirme abi.
15.
This is for circ.
So 3-5 in the circ.
Yeah.
Yes, good, good.
Okay, 14.
Taşıyorum.
Bunu da şişe abi. 14.
Şişiyorum. 2,
Şiş.
4,
14.
6,
14.
14.
Down. Go up 20.
14.
20.
16, 18.
Down. And now we do
Now
kissing.
Yes,
Wait a little bit and then
Yes.
kiss. Yes.
yes. Go up.
2,
2,
4,
4,
6,
6,
8,
8,
10,
10, 12, 14.
1,
1,
2,
2,
3.
3.
It's nice kissing.
Very nice.
Yeah. Didn't sleep.
So we'll see. Are you planning to do anything more, Ivis, in the meantime, or just
Yeah,
final?
let's do Ivis, yeah. I don't think we can do much more than that, to be honest.
Yeah.
You know, I don't know if we go bigger balloons, but let's do Ivis, yes.
Just to make sure, maybe there's one segment that we need to hit. more.
Sure, sure, I agree.
Aynen.
Before Ivis, do you want to see the some spider view and
Spider.
Yeah.
what do you think? Because it will be the final for us.
Spider, spider.
Spider.
Yes, yes.
Bir Pellingenit alalım. Pellingenit.
Ön şu, Pellingenit.
Ivis'u ver bana bu arada.
Hocam dışarıdasınız. Ömer hocam.
Oh, good. No problem.
Tamam işte. AP cranial.
Cranial.
Ah, you see that part? Still we have some eccentricity. See what I was says. AP cranial. Bir de buradan gösterelim.
Yeah, I think, but if you have achieved the
Little
good
bit.
MLA, there
Areo,
won't be
areo.
any-
Saga.
I think you-
Tamam.
Gir abi. Bismillahirrahmanirrahim.
Yes, we need more.
Yeah, it's okay. I don't think we can do bigger that
Yeah.
part.
That must be. I agree. That
I
must
can
be
have
great.
I can have a rupture if I go
Right.
with the 4.5,
Yes.
and I don't think I need it.
yes.
Yeah.
Big vessel anyway.
Is it enough?
This is
Haydi haydi.
Yes, okay.
Gelsene şöyle.
Daha gel bir saniye. Böyle çekmeyin bir saniye.
Okay,
No, it
let's
is
see.
enough, it is enough.
if we can have the screen on the Ivis run.
Oh, yes.
You will see it. Ne oldu Ayvuz?
Biz hala içerideyiz.
Göremiyoruz.
Ekranda bir
Ekranı.
şey yok.
Okay. Pull back please and 1 centimeter. 1 centimeter.
I was şey.
Bookmark.
Ekran şey.
Please show the Ayvuz at the big screen.
Set.
Su bağlayabilirler mi?
1 millimeter.
Yes,
Okay,
yes,
you
it's
see the
okay.
Ayvuz. Okay, yeah.
Yeah.
Pull back please.
Perfect.
Recording, yes. Okay, we pull 1 millimeter. This is a big septal.
vessel.
Big vessel,
Yes,
yes,
now
yes.
stent.
Big vessel. And stent is
Very
nice to
nice.
oppose.
Very nice.
I think 3.5 a good choice for
Yeah.
post dilatation.
I agree. Maybe that segment you can hit it
Yeah.
one more time with a 3-5
Yeah, this
again.
is all very calcified
Yes,
lesion,
yes.
but not
Look
bad.
here, they
This
expanded.
is just below the diag.
Yeah, yeah, just before, yeah. This is eccentric. Which part is this?
It
Yeah.
is the middle.
Yeah, middle. This is the
first,
middle.
Just below the diag.
Now
Yeah,
opening is okay. Aldım.
And you can probably check the MSA if you hit it one more time with a 3-5 and a 4-0 proximal. This looks actually really good, by the way.
Yeah, the proximal, yeah,
hard
that
part,
part
yeah.
was good. Yeah, I agree with
Yeah.
you. That part was okay. Yeah, the proximal part for a,
Is
I
enough.
think, good size. Again, another eccentric opening
Yeah, you can probably
because yeah, we have a dissection here
Some
and we have
hematoma.
heavily calcified lesion, and this is the left main
Left main, yes.
550.
Overall,
Yeah.
Overall, very
Yes.
excellent. I think
Nice.
Even
Yes,
those
stop.
areas, just hit maybe those two areas and then.
Okay.
below the diag.
So, do you want me to hit that part 3.75 or because?
Sadece
I think 3-5 at a high pressure. We
Three
went
se-
like 210 only.
Sorry? Ah,
3-5 with a high pressure.
yeah, but that
maybe.
part, no, that part we did
We
nicely.
did 3.5.
Yeah, that part done nicely.
It was
so-
still below the diag. I think below the diag we just went to 10s, no?
No, no,
Just
no.
above the diag
No,
we
no.
went high pressure.
No. Just at the once I went 10 and then easily I went 4. Let's see.
Let's see.
If you want me 3.5, it's better for me because then it's the risk is less.
Yeah, I know.
And if you will be happy, that part, you
Yes.
see, that part, I did it, I hit it
Yes,
3.5 big balloon, I'm sure. Let's do, I mean, we can do again once more.
I'd probably
Maybe
take
high
that
pressure
short
3.5.
375.
375.
375-10 or shorter.
Okay, let's do.
Let's do.
We have, if we need that, we have
We have in the
graft stand anyway.
We
have 4, yeah? Okay.
For the sake of time,
Or
I
we can
think
go
we,
do again 3.5 but for more
3.75 alalım.
3.75.
3.75.
Alamasa da var ama biraz.
Okay. Bu kaç bu?
So,
3.75.
I think in general, first of all, you did a really great job. It's really tough lesions throughout the LAD. Great job handling the complication, and you've demonstrated all tools in terms of the calcium modification and how you handled it very well. These things sometimes, as you mentioned, you would see an area that's underexpanded, or in this case, the stent itself expanded to 3.0. It's just the calcium on the one side. So hitting it one more time, maybe with an NC. If
Let's see.
you already have an MSA of 5, greater than 5.5, I think you leave it
Yes,
as
good.
is.
Let us see.
Just here. Okay. Go up. Yeah,
Yes,
here.
exactly, yeah.
Okay. 14. Let's do 14.
10, 12,
14, yeah? 14, 16. Okay.
16,
Okay. All right. Okay. Okay. That's good. It's open.
Yes, yes. It was good.
Yeah.
Hopefully. Let's see. Okay, let's see. Right.
Yes.
So,
Nice, yeah.
yeah, I mean,
Weak oils. Right?
yeah. So I wouldn't go more.
Yeah,
I
I think
agree.
we've done enough.
No, we will have rupture for sure
I
Yeah.
agree.
here. I'm sure. You know,
I think tracing it, I'm pretty sure you'll get an MSA
Yeah,
more than 0.5,
sure.
so.
if I go
This one-
bigger balloon, easily have rupture. I
think
guarantee
this
you.
long- This looks pretty good.
I guarantee you guys. And if I rupture and I have to put a graft, so the risk of stenosis may be higher
Very
than
high after two steps.
now.
50% in 1 year with graft stents. So
Yeah.
you're way better with this.
I agree. Excellent demonstration.
Okay,
Any final
yeah.
remarks from you guys?
Yeah,
All right. Thank you very much for your help and comment, guys. Thank you very much.
Excellent. And also a superstar team in your cath lab. They were
Yeah.
so quick with everything, remain calm.
All right, excellent. Thank you so much for joining us, and hope you enjoyed it as much as we did.
Great job, Rasha, with
Thank
dealing
you.
with all the technical complications.
Technical complications, exactly. All right, take care, everyone.
See ya.
Bye.
Bye.
Thank you.